eyelids and lacrimal apparatus. First we will discuss about eyelids. Eyelids, first glands of eyelids. Glands of eyelids include meibomian gland. These are the meibomian glands located in the tarsal plate, also known as the tarsal gland. They are modified sebaceous glands. They are modified sebaceous glands, and secretion constitutes the oily layer of the teophyllum. Oily layer of teophyllum. Next is gland of C's. They are modified sebaceous gland. They are also modified sebaceous gland. Next is gland of mole. They are modified sweat glands. And we have these are the gland of moles and gland of C's. Then we have the accessory lacrimal gland of Wolfram. Now coming to the inflammatory disorders in eyelid. Inflammatory disorders include posterior meibomitis or meibomitis. This is the inflammation of the meibomian gland. External hordeolum of eye is the acute suppurative inflammation. Okay, acute suppurative inflammation of glands of C's or mole. Your glands of this is external hordeolum styyi includes the gland of C's or mole, suppurative inflammation. Then posterior blepharitis or meibomitis include the meibomian gland, and chalazion or tarsal or meibomian cyst include the chronic granulomatous inflammation. Chronic granulomatous inflammation of meibomian gland. Then internal hordeolum includes suppurative inflammation of meibomian gland. Next, coming to congenital anomalies in eyelid. Okay. This is a meibomian gland, gland of mole, gland of C's, gland of Wolfram. Okay. Congenital anomalies of eyelid. It includes a congenital coloboma. It is usually in the nasal side of upper eyelid, usually in the nasal side. Then epicanthus is the most common congenital anomaly, and it is a semicircular. This is epicanthus here. It is a semicircular fold of skin which covers the medial canthus. This here is just epicanthus. Then cryptophthalmos is a cryptophthalmos. It is a eyelid fails to develop here. That is cryptophthalmos. Eyelid fails to develop. Next is epiblepharon. Epiblepharon is a horizontal fold of tissue right over the lower lid margin here. This is epiblepharon. Here, horizontal fold of tissue. The tissue lies above lower eyelid margin. Next is euriblepharon. It is a horizontal widening of the palpebral fissure. Here you can see horizontal widening of the palpebral fissure, that is euriblepharon. Now coming to eyelash disorders. Eyelash disorders can be different types, that is trichiasis. Trichiasis, we know that inward or turning of the inward misdirection of cilia. Inward misdirection of cilia. Now pseudotrichiasis is it is an inward misdirection of cilia along with lid margin. This here you can see the inward turning of the lid margin also. The inward turning of the lid margin is also seen along with eyelashes. In trichiasis there is only eyelashes, cilia is misdirected, the eyelid with the normal position of the eyelid. Distichiasis is extra low of eyelashes. And madrosis is partial or complete loss of eyelashes. Okay. Now coming to tumors of eyelid, papilloma. It is the most common benign tumor. benign tumor, and basal cell carcinoma is the most common malignant tumor of eyelid. Mostly involves the lower lid at the inner canthus. Next, coming to ptosis. Ptosis, it is abnormally low position of the upper eyelid, and we calculate for the margin reflex distance. It is the distance between the upper lid and the lower lid, margin reflex distance, and the corneal reflection of a pen is pen torch held by the examiner. The normal measurement is about 4 to 5 mm. Palpable fissure height, it is from upper eyelid to the pen torch, from the light source to the light source is MRD1, and from the lower eyelid to the light source is MRD2, and this is the palpable fissure height. It is the distance between upper and lower lid margin measured in the pupillary plane. The upper lid margin, normally this upper lid margin covers around 2 mm up in the upper limbus. Normally 2 mm is covered, and the lower lid usually just touches the cornea or 1 mm above the lower limbus. This measurement is shorter in males. It is about 7 to 10 mm in palpable fissure height is about 7 to 10 mm in males, and 8 to 12 mm in females. Ptosis may be graded as mild when it is up to 2 mm, moderate when it is 3 mm, and severe when it is up to 4 mm. Now, ptosis, the myasthenic ptosis may show an overshoot. The Cogan teachers usually seen in myasthenia gravis, like when there will be an overshoot of the upper lid on saccadic from down gaze to primary gaze, that is known as Cogan twitch sign, and open side gaze will be there. Now, congenital ptosis almost always requires surgical corrections. Then surgical correction include tarsoconjunctivo-mullerectomy, that is also known as Fassnella Servat operation. It is for mild ptosis. It is done for mild ptosis, and good levator function. Good levator function. Now, this here is the tarsoconjunctivo. See, tarsoconjunctivo-mullerectomy. This part is excised. Here, tarsoconjunctivo-mullerectomy. Next is levator resection. It is done in case of moderate to severe ptosis. Moderate to severe. Then frontalis ring operation. It is done in case of severe ptosis. Severe ptosis with no levator function. Next, coming to Marcus gun or Marcus gun jaw winging phenomena, trigemino-ocular motosynkinesis. It is an aberrant connection between the motor branches of the cranial nerve, fifth nerve, that is the maxillary division of the trigeminal nerve, and the fibers of the superior division of the oculomotor nerve which supplies the LPS. There is an aberrant connection between them. So, anytime the wing reflex consists of a momentarily upper eyelid retraction or elevation to an equal or higher level than the normal fellow eyelid upon stimulation of the ipsilateral pterygoid muscle. Upon stimulation of the ipsilateral pterygoid muscle, opening of the mouth or contralateral movement of the jaw, there will be eyelid retraction. This response is followed by a rapid return to normal position. That is known as Marcus gun jaw winging phenomena. Now, coming to next is Horner syndrome. Horner syndrome is characterized by due to the loss of sympathetic function on one side. There will be meiosis, narrow palpable fissure, slight inophthalmos, loss of tone of Muller muscle will be there, because Muller muscle is supplied by the sympathetic plexus, and absence of sweating will be there in postganglionic lesions. That is about eyelid. I have done separate videos on Horner syndromes and ptosis, so I will put the link in description box. If you are interested, you can watch that. Next, coming to lacrimal apparatus. Lacrimal apparatus anatomy. First we will come to anatomy. Now, there are two valves, valve of Rosenmuller and valve of Hassner. This is a valve of Rosenmuller here. It is present where common canaliculi open into the lacrimal sac here. And valve of Hassner, this is here, valve of Hassner situated here. It is present at the lower end of the nasolacrimal duct and prevent reflex from the nose. Valve of Rosenmuller and valve of Hassner. Next, teophyllum layer. Teophyllum layer consists of mucous layer, aqueous layer and lipid layer. Mucous layer is the innermost, thinnest Mucous layer, this is a mucin layer. It is the innermost and thinnest layer. It consists of mucin secreted by the conjunctival globulate cells, secreted by the globulate cell and the glands of Mens. Now it converts the hydrophobic corneal surface into hydrophilic. Cornea is hydrophobic and it converts to hydrophilic surface. There is a mucin layer. Next is the aqueous layer. Aqueous layer is the bulk of the tear film. It is the largest layer and it forms this intermediate layer which forms the bulk of the tear film. It consists of tears secreted by the main and accessory lacrimal glands. It consists of antibacterial substances like lysozyme, beta lysine and lactoferrin. Antibacterial substances like lysozyme, beta lysine and lactoferrin. Now coming next is the lipid layer or the oily layer. And it is formed by secretions of the meibomian gland, C's and mole glands. It prevents the overflow of tears, retards evaporation and lubricates the eye. Okay, this is the lipid layer. Prevents overflow of tears, retards the evaporation and lubricates the eye. Now next is tear film test include tear breakup time, Schimmer's test and the Rose Bengal staining test. These are the test for tear film. Now coming next is the watering eyes. Now watering eyes can be hyperlacrimation. Hyperlacrimation is excessive tear secretion, or it can be due to epiphora. Epiphora is obstruction to the outflow of normally secreted tear film. This is obstruction. This is increased lacrimation. Excessive tear secretion, hyperlacrimation, and epiphora is obstruction to the outflow of normally secreted tears. Causes of hyperlacrimation: primary hyperlacrimation is due to direct stimulation of the lacrimal gland, and reflex hyperlacrimation is due to stimulation of sensory branches of the fifth nerve because of the reflex secretion, and it can also be due to central or psychic lacrimation. Now obstruction, it can be due to defective drainage, that is due to malposition or obstruction of the duct, or it can be due to lacrimal pump failure. For clinical evaluation, we have to do the fluorescent dye disappearance test, lacrimal syringing test and Jones dye test. In Jones dye test is done when we suspect partial obstruction, and it is of no value then when there is total obstruction. Now in Jones dye test, primary test, it is to differentiate between watering and hypersecretion, between watering due to partial obstruction of the lacrimal passage and from that due to primary hypersecretion. Now 2 drops of fluorescent dye are instilled into the conjunctival sac, and a cotton bud dipped in 1% silocaine is placed in the inferior meatus at the opening of the nasolacrimal duct here. After 5 minutes, the cotton bud is removed and inspected. A dye stained cotton, that is positive. If it is dye stained, it is positive. Bud indicates adequate drainage through the lacrimal passage, and the cause of watering is primary hypersecretion if the dye is stained. While the unstained cotton bud, that is a negative test, indicate either a partial obstruction or failure of lacrimal pump mechanism. To differentiate failure of lacrimal pump mechanism, partial obstruction or failure of lacrimal pump mechanism. To differentiate between these two, Jones dye 2 test is performed. When primary test is negative, the cotton bud again is placed in the inferior meatus and lacrimal syringing is performed. Lacrimal syringing is performed, and here a positive test indicates partial obstruction, and a negative test indicates total obstruction. That is Jones dye test. It is usually done when we suspect partial obstruction. Now coming to next one is dry eye. Dry eye, it can be either due to aqueous deficient dry eye, that is keratoconjunctivitis sicca, or evaporative dry eye. The aqueous deficient dry eye, it can be due to Sjogren's syndrome or non-Sjogren's syndrome, keratoconjunctivitis sicca. It is non-Sjogren's syndrome, it can be due to lacrimal gland deficiency or lacrimal duct obstruction. Other causes can include other causes of reflex hyposecretion. Here, this is non-Sjogren's, okay. Now, reflex hyposecretion, that is familial dysautonomia. Parkinson's disease, seventh nerve damage, or post LASIK. That is aqueous deficient dry eye. Now coming next is evaporative dry eye. It can be due to meibomian gland dysfunction, lag of thalamus, defective blinking, vitamin A deficiency, or contact lens wearer, or allergic conjunctivitis. Now, diagnosis of dry eye. Diagnosis of dry eye is when time is, that is tear breakup time is less than 10 seconds, or tear lysozyme ratio is between 0.6 to 0.9, or Schimmer's test producing wetting is less than 6 mm. That is when we diagnose dry eye. Now, treatment is either we can give a tear substitutes, that is artificial tears like methyl cellulose or hypomethyl cellulose. Topical cyclosporin can be given in severe cases, like 1% cyclosporin can be given. Mucolytics include 5% acetylcysteine in severe cases. Punctal occlusion can be done. It is decreases the drainage, or permanent lateral tarsorrhaphy for severe cases can be done. For severe cases where medical management is not effective, permanent lateral tarsorrhaphy can be done. Next is dacrocystitis. Dacrocystitis is inflammation of the lacrimal sac. So, inflammation of the lacrimal sac is dacrocystitis. It generally affects two age groups, that is infants and adults more than 40 years. In congenital dacrocystitis, it is always chronic, and it is due to incomplete canalization of the lacrimal system, here, or most often at the valve of Hasner, due to incomplete canalization. Clinical features include epiphora, or regurgitation test will be positive. Just when we press on the lacrimal sac, mucoid fluid will come out, that is regurgitation test. Regurgitation test is positive. Then treatment of congenital dacrocystitis include, also for epiphora it includes, first step is massage over the lacrimal sac area and topical antibiotics. Then if it is not subsiding, then lacrimal syringing with normal saline, lacrimal syringing is done with normal saline and antibiotics. If not cured, after 3 months it is done. Then followed by probing of the nasolacrimal duct with Bowman's probe, if not cured, at 6 months. This is the Bowman's probe. Probing of the nasolacrimal duct is done. If it is chronic epiphora beyond 3 years, then dacrocystorhinostomy is done. Now, this is a Lester's John tube is placed in presence of persistent epiphora in a patient with less than 8 mm of the lateral part of the canaliculi. If only less than 8 mm of the lateral part of canaliculi is remaining, then we put a Lester's John tube as a connection. This is a Lester's John tube. Okay. Now, adult dacrocystitis is chronic, more common than in adult dacrocystitis. Chronic form is more common than acute form.